Dr. Stanley Aruyaru. Did I say your name right?
Correct.
Welcome to Investments for Impact, the Vulgro Africa podcast.
Thank you.
It's a great pleasure and honor to host you. As we were speaking earlier on, I told you I've seen you on TV, so you're a big deal. And we're happy to have you on the podcast.
It's a pleasure. Thank you. Thank you for having me.
Welcome.
Thank you very much.
Yeah. So to start the conversation off, just to paint a picture of what's going on, this particular season of the podcast is in the run-up to the Transforming Africa MedTech conference. And what we're doing is we're trying to bring guests to speak into topics around medical devices, why they're needed, and the conference will be the culmination of these conversations. And that's why we have you here as a clinician. So you can start off by just introducing yourself for the sake of our audience.
Thank you so much. Good morning, good afternoon, good evening. My name is Stanley Aruyaru. Stanley Aruyaru is a doctor with 14 plus years of experience in the Kenyan healthcare space. By specialty, I am a general and laparoscopic surgeon, and I practice at PCEA Kikuyu Hospital as the chief medical officer and a general surgeon. PCEA Kikuyu Hospital is a level 5 faith-based facility based in Kiambu County. Its brand is really the eye care, the care of eyes. So anyone with an eye problem will always mention Kikuyu. But besides that, we also have the general unit, which has medicine, pediatrics, surgery and obstetrics, ICU, radiology, dialysis, all those services. Then we have the orthopedic unit that deals with complex spine and back problems. And we have a dental unit. And we also are a training institution. We have a School of Nursing with a 100% pass rate on the Nursing Council. And we are trainers in specialist surgeons, both in general surgery, in orthopedics, and in eye. That is my work as a clinician. The other hat I wear is that of leadership in the Surgical Society of Kenya. The Surgical Society of Kenya is the umbrella association that brings together all surgeons with the mission of advancing quality surgical care to Kenya through training, through research and welfare of surgeons. There I serve as the Secretary General and also as the Deputy Editor-in-Chief of the official journal of the Surgical Society of Kenya. It's called Annals of African Surgery, whose mission is to be the premier surgical read in Anglophone Africa. But besides my professional life, I am also a speaker and I am also an author. I like to say that my brand is Sowing for Impact, where S is for speaking. Speaking to this podcast, speaking when I get an opportunity in conferences, in shows, like you mentioned, to advance advocacy for surgery in terms of access, in terms of affordability, in terms of safety. And you can catch a lot of what I speak about on my YouTube channel, Something About Surgery. The YouTube channel is called Something About Surgery. O is for operating. And I've already spoken. I'm a general laparoscopic surgeon practicing in PCEA Kikuyu Hospital and engaged with a lot of areas to push access to safe surgery, access to quality surgery to Kenyans in all corners of the Republic. Then W is for writing. So Sowing for Impact. S is speaking, O is operating, and W is writing. My first book is titled The Chronicles of a Village Surgeon. You can get it on Nuria Bookstore, and my second book hopefully will be out by the end of this year. And I also write several other things. I have a blog on my website, aruyaru.com. I get to do a few opinion articles here and there in any of our dailies and on my social media platforms. And I'm hoping I can do more and more and more just to give back to the society, or even to give the society when it has not given me anything. So I don't have to be just giving back. Besides my professional life, I am a husband to a lovely wife and a father to 2 adorable kids. And it's a pleasure to be on your podcast.
That's wonderful. And I find myself being very curious, Dr. Aruyaru. Why medicine? How did you find your way to that way of giving back to society?
Interesting question. I actually do not know, but what I have said previously is that when I finished my KCPE, I passed so well. I was the best that the school had seen, and my record stood for over 13 years. Wow. But my parents could not afford to take me to secondary school. So when my father went to pick the admission letter from the primary school to go to the provincial high school, the teacher asked him, "Where are you taking this boy who has passed so well?" And my father said, "I'm taking him to the village polytechnic, not the TVETs. Previously, there were village polytechnics where you do 6-month course and become a mechanic." So my father secured to take me to become a driver and mechanic as an artisan course in a local village polytechnic, because that is what he could afford. You know, we say you cut your coat according to your cloth, your size notwithstanding. And the teacher then prophetically told him, "No, don't deny this village our first ever doctor." But I didn't know I was going to be a doctor. Mm-hmm. Anyway, the long and short of it is the parents and the teachers from my primary school came together and stopped me and my parents in our mischievous way. So I'm going to the village polytechnic and conducted a harambe, and that's how I got to get to secondary school. When I got to secondary school, the teachers kept insisting on us. This school, that was St. Cyprian High School in Tigania. This school has produced all the professionals except 2, a doctor and a lawyer. And I was inclined to sciences. And therefore, as a science student, I was inclined to doing this lofty medicine course that the teacher keeps talking about. But I remember medicine in University of Nairobi was my first choice. Medicine in Moi University was my second choice. Then I had pharmacy and civil engineering as my other choices. So when eventually the KCSE came, I was lucky to pass, and I was happy to get admitted to Moi University School of Medicine. So initially, I do not know. But the moment I landed in the medical school, then there was this innate, indescribable drift towards surgery that then just made it an obvious specialization line for me through medical school. I don't know if that answers your question or it goes round in circles.
No, it does. Thank you
Yes,
so much.
Yes.
That's a very interesting story. And it reminds me of someone who once said, I don't know if it was Dr. Martin Luther King, who said that you don't choose dreams, the dreams choose you. Yeah, so thanks for sharing that. And it is a good segue to my next question, which is around our topic for today, medical devices. So as the Chief Medical Officer, maybe you could tell us what are some of the types of equipment that a hospital requires and what are they for?
That's a loaded question that we could speak to the whole morning, but I would first speak as a surgeon. When I get into the operating room, you will be surprised at the immensity of all the gadgets I have to use. First, the patient is on an operating table. This table is operated by a medical engineer because it should be able to rise to my level, go down if I needed to go down, tilt to the right, tilt to the left, tilt down, head up, whichever position I want, and take several beds and cups. So the operating table is the first thing because I have to place the patient somewhere. Then the operating lights, which are overhead. And sometimes I put heads on my head, you know. And these are also biomedical gadgets if you look at it that way. And then we have the anesthetic machine, which is essentially the life support machine when the patient is being operated on. And that is supposed to be tricked in a way to deliver adequate doses of anesthetic so that the patient is not completely knocked off and dies, that is overdosed, and is not underdosed so that they feel pain or they wake up and start kicking the surgeon when the surgeon is operating. So the anesthetic machine is there, the operating table is there, the lights are there. Then it depends on which operation I'm doing. Sometimes, like this Monday, I'm going to be doing something called laparoscopic procedure, so there's a tower a whole laparoscopy tower which has got the camera that is getting into the patient belly, it has got the processor of the image, it has got the screen, it has got a gadget to blow air and create space where we are operating. So that's a gadget by itself. Then I have energy devices, something we call diathermy, because if you're using electrocautery to minimize of blood loss, then there is a circuit that is getting electricity from the wall, converting it into certain current and delivering that current through a special blade called a diathermy blade or diathermy pencil. And depending on other procedures, then you can have another gadget, a different gadget, you name it. The setup of the entire operating room itself is such that there is conduit for medical gases, there is conduit for oxygen, there is conduit for medical air, there is conduit for suctioning because you need to suction things out, there is air conditioning. So essentially I am surrounded by biomedical gadgets and appliances. This is as a surgeon. But as the chief medical officer, if you look at every unit, it will have its own equipment. If you look at the ICU, there is all the life support machines per bed. There are all the patient monitors per bed. There are all the examination lights per bed. And again, the configuration of the unit is such that then you have the air evacuation system, or what is called the vacuum system. You have the suction system. You have the oxygen delivery again. And that is just one unit. You go maybe to the dialysis unit, and every single dialysis unit again has got its components and its peripherals. You go to the eye unit, and now you introduce microscopes because my eye surgeons have to operate using microscopes. You introduce different machines. You go to radiology, you introduce gadgets that are very good to give the doctors the diagnosis, but if not controlled, they can easily be dangerous because radiation has to be controlled. So if you over-radiate the patient, you cause them harm. But you need to expose that radiation a little bit to capture an image that shows the doctor what is ailing the organs inside. So you have the X-rays, you have the ultrasounds, you have the CT scan machines, you have the MRI machines. That is with the X-ray department. You go to the laboratory, all the gadgets to analyze all the, lab tests that you need, any manner of lab test. And therefore, as you take an aisle walk across the laboratory, there will be all manner of gadgets, some interconnected, some standalone, some controlled remotely, etc., etc. And I have not spoken to, the rest of the machines that must support the operations, supply chain networks, ICT gadgets, CCTV for security and all that. So it's a whole gamut. I am controlling the human factors the human resource, but there's a lot of machine support, and there is nothing as fast moving as the revolution in the health gadgets or the equipment and appliances industry in the medical world that I feel we probably do not speak a lot about them because those are the robust diagnostic supports that help us. Sometimes, even in medical legal setups, the doctor says this, the other doctor says this, and sometimes the tiebreaker is the scan. They want the scan show, because then the scan is incontrovertible. What it showed is there, you can always go back and refer to. So there is a lot of diagnostic support that make our healthcare work. And without them, we will be completely rendered, paralyzed to make a diagnosis. And we'll keep referring everyone, go to that hospital because they have this imaging, go to that hospital because they have this machine, I don't have this machine. So it is the centrality of these machines that I think makes this conversation and the conference you're planning very important for us, especially when we are, having the conversation about UHC and what exactly should UHC mean, because it should be quality. It can't be just, I've examined you, and now you go, whatever else you have, I don't have the gadgets to do the investigation. So I would say the biomedical gadgets are part and parcel of healthcare as we deliver it today.
So, Dr. Aruyaru, as you spoke about the number of gadgets and equipment in a hospital, I mean, I'm a biomedical engineer and I was overwhelmed. So it makes me start wondering, you as a clinician, you see these equipment and you need to use them for the work that you're doing. But then there's the biomedical engineer who is at the hospital. To what extent are your biomedical engineers supporting you to understand what equipment you need to take care of that equipment? What is their role in all of this?
Thank you, Amboy. I think their role cannot be overemphasized because, like I mentioned, for instance, in the case of an X-ray, if the X-ray is not calibrated properly and it is delivering higher radiation than normal, you've basically shifted from offering care to causing harm. And one of the core, ethical principles of medicine is first do no harm. Once you are done with that, anything else follows. So usually that then tells you the gravity of the issue of the biomedical engineer. But let me come to your question. Your question is, maybe I have 110 equipment and I have one biomedical engineer. Is that ratio accurate? And the answer is no. The answer is no, because if we've got 3 machines failing at different corners of the hospital and you have a patient there, then you have exposed that patient to significant risk. So I would say, for instance, that I have always observed the distribution of biomedical engineers in our facilities may not be adequate. In fact, my argument has been in recently from where I am and just from my liberal thinking is that it is now time to outsource our biomedical engineers by way of establishing service level agreements with whoever supplies you. Why? For 2 reasons. Number one, the number of biomedical engineers we are training may be not enough, or they're enough in terms of the training, but they don't find their way into the workplace where I interact with them, where I tell them, as I set up this machine, I need you to be here, and tomorrow I need you to do a dry run of this before I start it. Suffice it to say that the people who are using the gadget, me as a surgeon, the nurses who are operating with me, the anesthetists, more or less have been trained on the job to troubleshoot with the machine and work with it most of the time. But ideally, the biomed should be at our beck and call. But sometimes you call them and you may have to abandon some intervention procedure because the biomed is being held up in another wing of the hospital. So that is one. Number two, we have always observed, there is statistics saying that the half-life of medical knowledge is, around 18 months. Like if I still like this without reading, 18 months down the line, I will half of the knowledge I know will be obsolete because of the rapidity with which the knowledge is turning. And then that brings the question. I have a biomedical engineer who was trained 10 years ago, and there is this robust change of equipment day in, day out from different jurisdictions, from the Americas, from the European Union segment, from the Asia. And you ask yourself, how well updated are they? Especially when you come to a situation where, as doctors, and I'm sure in most other regulated professions, we get our CPD, continuous professional development points. For you to renew your license at the end of the year, you must get that. We don't have that robust mechanism for our biomedical engineers. So there might be nothing external. There is no external motivator to make sure that these people are getting kept abreast. So you can have a situation where the machine is aging, the biomedical engineer's knowledge is aging, and there are new, there are new people who are coming on board, there are new machines that are coming on board, but that person is stuck with the model they were taught with in college.
Yes.
And the new models have come up. So this is the conundrum we find ourselves in. And if I was to suggest just one single bullet shot, it would be purchase anything, have a service level agreement with. So that the role of your biomedical engineer is detect and alert. Detect there is an error with the machine, alert the remote supplier, because they have given you this service level agreement and they are available to come and service your equipment at a short notice. So I feel like that is where the conversation will be, because the more we say let's hire more biomedical engineers, the more the question of how up to date are they? And sometimes the budget line does not allow for us to keep them as up to date as they are. Today there's a new model of machine, but if the one I have from 7 years ago is working, why then should I have this? So it's a difficult conversation to continue. And I remember when we had a phone conversation asking you one question: what will prevent, and this is now the difficult bit, what will prevent a manufacturer from behaving the way some phone companies behave? They want to roll out a new model, they create a bug for the old model, and therefore you are sabotaged to drop your phone to upgrade to the new version. What will prevent them, especially if they are not within our geographic and geopolitical jurisdiction, to do that? They can remotely call from abroad and say, we are now decommissioning this model, and you had just received it. You had just bought it after 2 years of procurement process and raising money. It was placed at a down payment. And now when you just finish to pay the final coin, and then they say, we are decommissioning this one because we have a new one, because they just want to push business. And then you're stuck there, and there's nothing you can do for them. And that's the question that we preach every time. But if we had an SLA, then maybe we could handle it. Maybe we could handle it, because if they want to overhaul it, maybe we just need to pay a little something and they carry back their machine. Number 2 is donations. I have worked in mission hospitals and we get donations a lot. Now, when you have a donation of a huge equipment, maybe the person who donated didn't donate a brand new equipment. Maybe they were upgrading, so they told you, take this one, it can serve you another 3-4 years. And therefore, you get to a point where you have a biomedical machine. It's been working perfectly. Brand, these brand models that, this one has been tested and proven. But over time, you are looking for parts and you can't find them. I have so many machines in my hospital now where my biomedical team and procurement are asking for parts, and the engineers are saying they are no longer in production. And now you have to come and decommission the machine even before you've reaped benefits. So maybe the conversation on top of the magic bullet of service level agreements, where the supplier takes care of the machine and you are paying a retainer, if we can call it that, is also to talk to what Wambui was telling me the other day, and I would like her to weigh in. Can we have local assemblies? Because once you have local assemblies of these gadgets, then you kill 2 birds with 1 stone. You make sure people training in the colleges go to those assembly lines and work with a gadget that we are assembling, and it will be delivered to Kikuyu tomorrow. So I can go for attachment next week and I will meet it there. So we are not using old models that, were bought and now we don't have new budget for CapEx. Rest in peace, finance bill. and now you have to start afresh. And number 2, you can regulate. Number 2, you can regulate, because when the assembly parts are coming, you can assess and you can give your own seal of approval. But if I want to import a gadget and I get PPB approval, once I get that initial approval, I don't really care. This guy will keep importing as long as it's labeled, Maono. I say, I approved this thing 2 years ago. But how many people will give you the perfect product for checks and approvals, and then they reverse engineer things and give you something that meets their budget, especially when it comes tagged for Africa, for low and middle income countries, for developing countries. Sometimes it's low quality stuff that you are just being enticed to pick because it is cheaper, but maybe the quality is not there. I don't know what Wambu you think.
That's a very good point. You made some very good points, and I think the other piece of that is the fit for purpose. If we are assembling and getting to some point where we are manufacturing our own medical devices and equipment, then we can make sure that they work for our environment, which is an environment where we have power issues. Internet connectivity may not be perfect. There may be dust, So all of these things, as we are thinking about which ones to assemble and eventually which ones to manufacture, we can really think intentionally about what it is we want to put in our hospitals, and working with clinicians and hospital administrators to understand what the needs are, what the cost implications are. And I don't just mean about buying the equipment, but the whole life cycle of the equipment. How is it going to be serviced and maintained? And like you said, if it's being assembled and the biomedical engineers are part of that process, then you're really taking account of the whole life cycle and end of life. What is going to happen to that equipment when it needs to be decommissioned? Is it going to end up in a graveyard at your hospital, or do we have a plan for recycling some of the parts and getting rid of it? So it puts us in a place of being able to control what we want to do with equipment, with the training of biomedical engineers. And I completely agree with you that that's where we need to start going.
Dr. Aruyaru, you raised so many important questions. You raised the question of distribution of biomedical engineers. Are we even training enough biomedical engineers? Because even if we are to have service level agreements, we will need those companies to actually employ biomedical engineers. And we are assuming that we are training enough for them to be employed and then to be sent to deliver on the SLA. But part of the reason we are having the conference is because this is an important issue that is neglected, and we want to bring this conversation to the mainstream. And as part of that, we want you to help us understand, how do these things affect the patient? Now, a lot of people can say, I'm not an engineer, I'm not a doctor, but everybody at some point is a patient. So if you could bring this conversation to the patient level, what does it mean for me when I'm a patient? What does it mean for my relatives when they're patients? And also thinking about issues of cost. You talked about Kikuyu being a level 5 hospital, and the kind of equipment you described for us suggests that you have a big equipment budget, but how does that situation reflect at a lower level of health facility? So many questions wrapped into one. Perhaps you can start with the impact for the patient.
Very good. Brilliant questions. Are we training enough? That's the question. Then I come to the question of impact. Probably not. The much I've managed to read, there was a lot of activity around the 2015 when there was a suggested bill for regulation of biomedical engineers by a member of parliament. And I think eventually it was suggested that it gets into the Health Bill 2015 to be incorporated inside. But at that point, when they quoted some, experts in the field, it was a paltry, very few people, in terms of biomedical engineers that we had in circulation. And when we looked at them, it was negligible, the ones that you can say these are bachelor's graduates. So you either had few diploma and multiple certificates, because you are those now taking these courses in the KMTC in Meru, I think in Eldoret or somewhere in North Rift, and the former Mombasa Polytechnic is now Technical University. And as we speak, I know it's only 2 universities that are offering the bachelor's degree. Now the problem becomes also their absorption. I remember Wambui telling me the other day that she knows biomedical engineers who have graduated, but they're working in banks because the space has not opened up. So that authority quoted that what we used to call the district hospitals, which most of them now are county hospitals or level 4 facilities, if you use the medical council leveling, should have at least 6 engineers, biomedical engineers. Your guess is as good as mine. These facilities, you'll find 2, you'll find 3. The other person is what is called a maintenance person, who is doing plumbing and wiring and cutting and doing everything, fabricating everything. Then they said the former provincial level hospitals, which were the 8 in every province, and then there were another 8 facilities called level 5. They were being called level 5. That was the introduction of the one level 5 before devolution, because you couldn't say you have more than one provincial hospital in the same province. For instance, in Nyeri, in Central, you would have Nyeri as the Nyeri Provincial Hospital, but then Vika became so busy that its productivity and magnitude of work could be equivalent to a provincial hospital, but you couldn't have 2 provincial hospitals in one. So you ended up calling Vika level 5 and level 5, so that Nyeri becomes Nyeri Provincial General Hospital. You had Embu level 5 for the Eastern Province, but Machakos and Meru were so busy that they were equivalent, but they couldn't be called provincial hospitals or provincial general hospitals, so they were called level 5 hospitals. Anyway, when you looked at all those, then they said we should have at least 16. Now, if we go back and count them, we will answer a satisfactory no, we are not having enough. The question of training, I might not address myself to that, but the question of absorbing them in the hospitals is not adequate. But let me come to the impact. And I want to address...
Just before you go to the impact.
Yes.
It's very interesting that you're citing a problem. We need more. You work in a health facility. And then on the other hand, we are saying we're not absorbing them. Why do we have that kind of situation where there's demand and there's supply, but there's no absorption?
And we need to have this conversation with academia, who is actually coming to the conference in August. We actually have several people who lead biomedical engineering programs, not just in Kenya, but across Africa, who are going to be there. And I think it would be very good to have this conversation one-on-one with them. One, are they training adequately so that when you get those biomedical engineers, you now don't have to worry about equipment? And then two, where are these biomedical engineers if you need them? And they'll probably push back to you and say, why aren't you hiring our biomedical engineers? So, and where are we?
and that's what Moses pushed to me, but she is suggesting we defer the question to the conference. Anyhow, the question is this. There is always a statement when you are doing budget that the means are infinite, but the resources are very finite. So if you come to me at a hospital setting and you ask me, do I hire an extra biomedical engineer or hire an extra 2 or 3 nurses? You can see where the catch-22 situation will come. But the place I work mostly is a plug to the public health system. The private sector is a plug to the public health system. So much so that there are certain cadres that, for the purposes of the business model, you will expect that this must be, the tone must be set in the public sector, and at the private sector, we can always complement. So maybe to look at a private hospital or look at a mission hospital and assume that you can look at the ratios and use them to set the benchmark, it might not be accurate. For the nursing, it will be accurate because it has reciprocal direct impact on the patient care. If the WHO says patient to nursing ratio for a ward should be 1:4, I expect when I come it will be 1:4. Otherwise, there's a patient who will go without medication. Otherwise, there's a patient who will skip wound dressing because the nurse cannot do all of them. That is service industry. Then the support services is now where the question is. And I would assume that the ministry, which sets the policy and the staffing norms, would say, if you are level 5, which is what I was quoting, this source was heavily quoted from the ministry. If you are level 5 hospital, minimum you're going to have is this. And then the council will come and say, if you are level 5 hospital and you don't have this number of biomedical engineers, you are not getting the license. Over my dead body. But that is not the situation. And then you look at what we have painted and you ask yourself, if I want to lump biomedical human resource budget and biomedical equipment budget together, if I go the service level agreement, would it be better in terms of a safety net, in terms of insurance, in terms of the bottom line? And I think this might be the area that the private sector and the mission hospitals are playing in, where I will say, yes, I can hire an extra biomedical engineer, but I know the ecosystem we are prevailing in. I know tomorrow I will have a new equipment and I still have to train him. So do I train 10 to agree to a certain norm, or do I train 3 and then have remote support for another 7, which will be onboarded as part and parcel of the purchase agreement with these suppliers? So that would be the more logical business case conversation for me if I'm a leader of healthcare in the private sector or in the faith-based space. Whether they call it faith-based or whatever, it's private anyway if it's not public. The colleague in public hospital who is setting policy, which is the Ministry of Health, needs to tell the county government, you have a county referral facility, you need to have this number of biomedical engineers to ensure that your equipments are working. You have this number of equipments of this caliber, you need that. So this is a conversation that can go on and on and on to then see academia, why are you training them to go to the banks? They can be training because they will go to the banks, they will find better use. Why are you training them to dump them in the banks? The other bit of absorption, still in the private sector, is in the gadgets manufacturers. I know engineers without number who have resigned. I call them and ask them, are you still in that hospital? I want some help. They tell me I left. I work for this gadgets industry as their key salesperson, as their technician. And therefore, when I come to pitch, I not only pitch the bottom line and the business case, I also pitch the physiology and the physics of this gadget, the technical bit. So you see, so they find their use better there because they are in the line of what they studied.
And paid better.
And paid better, absolutely. Paid better job satisfaction, because the fancy toys you are reading and watching on YouTube are happening there in the production line, and you can see them. So I feel they are plunging the gap. I don't know exactly what the numbers look like. It would be something would like to maybe investigate a little more and have that conversation. And I look forward to what people would have to say, especially from the regulator and the policy director, which is the Minister of Health. And then the real players in the industry, us who consume the services of the biomedical engineers, and the biomedical engineers who have graduated but they don't know where to ply their trade, yet they have been trained on the sweat of the brow of the public purse. Now the question of impact. I said healthcare is mechanized, and much as it remains the doctor-patient interface as the cornerstone of the healthcare provision as a service, that doctor needs to be facilitated by a lot of gadgets. So I see it as a quality perspective. And every time we discuss quality in healthcare, we talk about a model called Donabedian model of quality. It looks at three things. 1 is structure, 2 is process, 3 is outcome. In any hospital, the equipment will affect all those three. When you want to accredit a facility and you come and say, we want to assess your structure before we go to process and outcome, we will ask, you are a big hospital, how many specialists do you have? That's part of the structure. How is your organization organogram? Do you have a CT scan? Do you have a big machine? Do you have all this? So if you have that, then it is assumed, surely if you have a trained consultant, I expect they will give a better quality care than a facility without a consultant. If you have an MRI, I will assume you will have better diagnostic care than a facility without. So this is the reason behind the Donabedian model of quality in healthcare, looking at structure as one of the things that we must assess when we are looking at the quality of a facility. Then you come to the process. And the process you're asking, what is the turnaround time? What is the experience of the patient as they journey through the hospital? Now you see where the machine comes. I see you within 2 minutes, I tell you, you have so big a problem. Go to that CT scan and go to the MRI and go to the lab. And then you go to the lab, the machine is broken down. Quality is affected. The process, the patient experience is affected. I tell you, go to the machine, the MRI machine. The MRI machine has just burnt their UPS because there was a power surge. Quality has been affected. But even more importantly, I tell you, go for this test. The machine is not calibrated. It brings me bad results. I treat you on the basis of the bad results, and therefore I give you a drug. And a drug given for the wrong indication is poison. So I give you a drug for the wrong indication, that is poison. So you can see if the machines are not working optimally, or not working at all, or not calibrated, or not cross-checked, the process is affected. So we've spoken about structure, we've spoken about process. Let's talk about outcome. What is outcome? How soon do your patient go home? Did they get hospital-acquired infection? Did they fall? Did they die? So if the machine gives you the wrong result and you give the wrong treatment and the patient complicates, the outcome is bad. If the machine breaks down and a patient who needs cancer radiotherapy cannot get cancer radiotherapy because the parts have to be imported over 6 to 12 months period, and there is a war in Gaza, and we are importing from an Israeli company, pardon my political inclination, then the whole shipping supply chain logistics come in and bottlenecks come in. So you keep referring them. You wanted to catch the cancer at stage 3. By the time the equipment is back and running, the cancer is advanced. Outcome is being affected. This is the nature of the biomedical equipment, but patients do not understand. Because even doctors may not understand until you're thrown there now, where you have to chase a broken down equipment, look for the supplier, and they tell you didn't pay us, or look for them and tell you these parts are no longer in production. Then you pay them and you give a down payment of 1 million shillings, and then they tell you in 6 weeks' time, this is our delivery, 4 to 8 weeks. Most of them always right there. Delivery period 4 to 8 weeks, warranty 12 months, and payment period 50 upfront, 50 on delivery. 6 months down the line, you are waiting. And they tell you, oh, there's a shipment, or there's some issue at the landing. The logistics just run you mad. So those are the support. Those are the support. And if the supports are not working, and if we cannot bring the latest equipment because we don't have the experts to contain them, or the budget is not enough for us to get the latest, then you end up sending patients to India. You end up sending patients to Middle East.
At least the ones who can afford.
They fundraise on our WhatsApp platforms. They fundraise on our platform. You send them to get a PET scan because a country 63 years down the line doesn't have a PET scan. This was the case 5 years back. I had a patient, I write about him in my book. I had a patient, they hadn't go to India for PET scan. And then I've got no idea what happened to India, to them in India, because they came back, complicated, and they couldn't survive. And the stories are more. So now, thank God, at least you have another PET scan in KU, a PET scan in Aga Khan. I think Nairobi West also is installing theirs. I think Ruai family is installing theirs. So why did it get there?
Yeah.
Why did it have to wait until suddenly the private sector realized, oh, people are flying to India. Let's bring this business back. Whereas the ministry could best set the policy.
There's something you said to me when we talked a few weeks back that stayed with me, and that was that if you have a doctor who makes a mistake, there is a process. You can either you can talk to them, you can censure them, or you can fire them. When equipment makes a mistake or breaks down, it's a very hidden mistake. You can't censure the machine, you can't fire it. It really stayed with me that the biomedical equipment issues are a very hidden issue. They are not something that people think about, talk about. They are not out in the open. And that is something that we need to talk about more so that people understand when you go for medical care, there's the doctor, and that's who you really, and that's what you say, that's, your first line of contact. But if all these other things are not in place, if the equipment is not in place, if it's not well maintained, you're in as bad or maybe worse of a situation as if the doctor is not there that day, right?
Absolutely. Thank you for reminding me that. And it's something that, I'm reading about and trying to write about, is that hidden absconder called the machine downtime. When we have human resources, we set biometric clock in, they sign in, clock in and clock out, register, everything, they are there. But if you quantified, and in my hospital with my team, what we call the clinical excellence multidisciplinary team, part of the statistics we review month on month is what we call machine downtime. So that we quantify them. How many minutes is this machine down? How many minutes is this machine down? If you looked at the machine and asked yourself, what is the human resource equivalent of all our machines? And you said, maybe in the sector we play in, maybe our human resource equivalent of our machines is 50%. And then you asked yourself, so 1 minute of machine downtime is equivalent to how many minutes of absconding duty? You will realize the hidden human resource trouble in our healthcare system. Today, the server is down. There's a downtime because the baby shark ate the underwater sea cable and we have no internet. Then the UPS has blown up, and then the X-ray has broken down. The parts are not there. You quantify them and you are hemorrhaging. It's like you are a perpetual alcoholic who does not report to work, or reports to work and hangs the jacket and goes to take a booze, or just comes and sleeps. Basically, if you looked at it from the human resource perspective, you just look and say, okay, so this is equivalent to me having 10 abscondees per day for a year running and I'm doing nothing about them. No one looks at it that way. No one looks at it that way.
Do you mind actually telling us what your downtime is at your facility? Is that something you can talk about?
Maybe I will say it might not make sense.
Maybe an example.
Because it needs to be packaged. Mm-hmm. So maybe I can share how we quantify it so that if you can connect dots and see trends, then someone can act on data. So for instance, once we have the autoclave is this big machine that is supposed to sterilize surgical materials so that you're using sterile sheets and sterile equipment when operating. So for instance, if the autoclave has burnt its elements, like the way the instant shower burns elements. So the autoclave has burnt elements and therefore it stopped working. We start counting and we document that. The moment an X-ray breaks down because either there's a software error and the X-ray cannot directly print into the film and the printer is not working, or the UPS has gone down, we document that. Now, once it is back up and running, we stop the counter and then we calculate that. So what we do is lump all this and ask ourselves, as a hospital, how many hundreds of minutes of machine downtime did you have? So it's not a static figure. Because I might tell you what we discussed last Friday, and then the end of this month, when again we review the statistics, we realize it has gone up because an extra machine broke down. Or it went down because we are under constant supply or something like that. I don't think it is a popular thing people do, but I found it very useful because then we know our constant problem is this. And it will have obvious effects when you review the customer feedback reports. They will say, I will kept for long at the X-ray. I will return and told to come tomorrow. All these are affecting the client experience. And being a service industry, if your customer experience is not good, you can as well close shop.
Maybe a different way of looking at it would be, if you were to look at the macro level, to what extent does equipment contribute to our national mortality and morbidity statistics?
That's a tricky question and it's very difficult to answer. It's very difficult to answer for several reasons, but one of them is something called the Swiss cheese model when you're talking about complications in healthcare. Swiss cheese model envisions that you have, I don't know why they call it cheese. It's just, say you have a loaf of bread with several holes in the center. One hole is at the center, another hole is at 7 o'clock, another hole is at 6 o'clock. And it's, for that loaf to remain a loaf, you need slice number 1 to slice, how many slices are there in a loaf? To slice 23 aligned. And you can put maybe a toothpick through this hole, and maybe a blade stem through the other hole, and a spoon or fork through the other hole. They are aligned like that. To maintain that, the model envisions that every time a patient dies in a facility, it is easy to point to Dr. Aruyaru because he was the last contact. But when you look back at the system, you realize from slice 1, the holes were not aligned. They came and the askari spoke badly to them. When they parked the car, they hit the curb. They came and there was a downtime in the registration. The person who was reading the ID entered the last digit wrongly, so they picked the wrong name. They didn't give them a tag. When they went to the washroom, someone had forgotten to wipe the floor. They slipped and fell. By the time the patient has complicated or died, there were so many contributors. So it becomes difficult to quickly say, assign this to the machine. But if there was a machine to be assigned to a patient dying, it's only one machine. It's a life support machine because it's the one, if it falls down, the patient will die. Luckily, the engineers here, they are brilliant. They set the machine with its internal, battery. And when you are setting it up, you run it before you connect to the power so that you can know if there is a downtime or there is a power outage, it can sustain me for 30 minutes or something. And then you have now mechanisms where the caregivers can, you take over the breathing of the patient, start bagging them, and contain it. So it won't be calamitous, dramatic fail. Power off, patient dies. That doesn't happen. But you can imagine how this would contribute in the long end. You can imagine if today there is no single dialysis machine working because there's a national outage and the generator has refused to kick in, and you have to call people and come and try it. And then all these patients miss their dialysis today, so they are supposed to come tomorrow, and then they have complicated. You know, I used to say there are certain movies, I don't know which Western African country they come from, where someone is shot and then they die instantaneously. It never happens that way. It never happens that way when patients die. When you trace a patient who is dying now, they started sending you telltales 5 days ago. That is the problem. So I can't pick and say, oh, this machine failed, so he died. But you can imagine today the machine downtime has failed. We can't operate the theater for 6 hours. A patient who was scheduled for emergency surgery and whom by our projection was, if we don't do this surgery within 24 to 48 hours, patient will complicate. That disruption will push down the line. So the patient gets delayed care. And one of the domains of quality healthcare is timeliness, to avoid harmful delays. So patient who was supposed to have this procedure going easily, nicely, and recovering, now is having the procedure as an emergency because they have complicated. They have bled a little more, so they are on the verge of shock. But of course, the human body is such that it will fight this. It will fight if the kidney is failing and they have not gotten dialysis. It will fight if it is bleeding and there is no gadgets quickly enough to prepare for emergency life-saving surgery. The body has mechanisms to try and survive. This is evolutionary, but those can only be held tight for only so long. So I can't say this is the direct impact, but you assess the healthcare system, and that's why the tracking I was telling you about machine downtime kind of tells you if the processes are not working well, the outcome is going to be impacted. Unfortunately, it's not black and white. This has failed, this person has died.
Okay, can I ask the question a different way? Because you're the chief medical officer of a hospital. In the work that you do at the hospital,
Yes.
where would you rate the biomedical, the equipment issues as part of your job? Are they the most difficult? Are they somewhere near the top? Are they so minuscule that you don't worry about them? Where does it rank?
Absolutely, they would be top 3. They would be top 3. They would be top 3. It's just around human resource, it's around the customer experience, and around the machine downtime in terms of supporting us. Okay. Yes, and when you say that, you say because either the machine do the work so well, you know, sometimes it's also easy to criticize, but it's also good to look at it in the lens that this place, like my eye unit, my doctors can only work when they have a machine called slit lamp exam, when they have a machine called a microscope, when they have a machine called sijui ferros, sijui this, like everything is happening. We are seeing 200 patients a day on average in the eye unit, and we are doing 40 surgeries a day in the average in the eye unit alone, not the other units. And therefore, you post back and say, all those are not just hand surgeries, they are mechanized surgeries. So assume if all the machines were not there, it will become top 1. Yeah. So it's, you know, it's always a podium finish for the machines in the facility where I am. Podium means gold, silver, bronze, depending on the prevailing day, but it's top 3. Yes.
Awesome.
Yes.
Yeah. So thank you very much, Dr. Aruyaru. I think maybe to just conclude, 2 things. One, you surely must come for the conference. we need a commitment from you that you will come, because we would like you to be part of the discussions. But maybe as we close, you can tell us what would you say very briefly is the role of the clinician, you know, in creating change in this space? What can you do as a doctor? Of course, through the conference, we're looking at the entire ecosystem, but what would you say is the unique role of the clinician?
Thank you very much. First commitment, I had spoken to Wambui earlier, and I said I would be happy to attend. I just need to see the program. I saw the flyer, brilliant flyer, in terms of the concept of what you intend to do. So I'm happy to come and speak on behalf of Surgeons of Kenya, on behalf of PCEA Kikuyu Hospital, but even on my own behalf, let me know the program, I might not be there for the whole 3 days, but surely I should be able to, make a talk or appear in a panel discussion once you let me know. And I had shared that Thursdays would be better for me because Wednesdays I'm in clinic the whole day. But Thursday, either morning or afternoon, I will see how the program looks like, or Thursday. So we just plan in advance that I am able to block it so that I make sure to attend. The question you have asked is very good, because I know as clinicians we can throw hands in the air, not literally, and say, that's not my problem. I have come, the machine is not working, I have gone back home. We can do that, but we can do what I say, wearing the customer shoe and the boss's shoe, which I never used to do until I was given this office. Previously, I am a surgeon, I am here, the machine is not working in theater, cancel the list, I'm not operating. So that used to work, but also it never used to close the loop. It used to work because you set the standard, and this is what every clinician is able to do. You set the standard and say, this machine is not doing this, I'm not working. No one will bring you with a gun to your head or abduct you and force you to operate or work when you don't feel comfortable with the machines you have. So you drive change from them, because that's how the people realize, okay, Dr. Aruyaru cannot work. If the X-ray viewer in his consultation room is not working, he will just go back and say, call me when it is working. But you also have now to say, how does it affect management? How does it affect the patient? So when I started wearing both shoes, the patient and the boss's shoe, I would ask myself, if I was the patient and this has happened, what would I expect? I would surely expect the doctor to come and explain to me, sorry, we are going through a problem. There's an issue with the gadget. We might not be able to see you as robustly as we wanted. So either we can postpone this or this other alternative. Most of our patients just are waiting for communication, to be told this is the problem and this is the mitigation. And what would my boss do if he heard that there is a gadget that's not working and the doctor is saying they are not doing? The boss will assume that the doctor has explained to the patient, not to the patient, go to the CMO's office, he knows the problem, or go there to the CEO's office, this is not my problem. If I was the boss, I would expect my doctor has made the patient understand, because there is a certain moral authority and pedestal that doctors occupy when a patient comes to consult with them. But also, if I was the boss, I would want to find what is the corrective action I can start at the moment. And what I have shared is, one is making decisions driven by data. So if you start collecting data, how many clinics you are canceling because this thing is not working, they will trickle to the management, because most of the senior management is really data driven. This is one, okay? And the most important thing is then create policies that say this is what we are going to do, and projections. For instance, in Kikuyu, what we've asked our biomedical team is to give is, on top of giving us the PPM schedule, what is called planned preventive maintenance schedule, it's also give us, I don't know if to call it, in finance they call it aging report or whatever for debts, but if you can just give me a matrix that says this machine was manufactured for this period, it has a lifespan of 1,000 hours, it is 5 years old, we should plan to lay it off next month or next year. That way then we are able to capture it in the budget and say next year, before the machine breaks down and the biomed removes the yellow wire, the green wire, and pushes the transistor or whatever you call those gadgets, and finally says after 6 months of hard work, it is not working, we should have said the designers who are in a very controlled environment in Germany or Japan, not where the humidity or the salt levels are skyrocketing that they never even imagined, the designers of this machine envisioned that it will work for 5 years. You are now on the second bonus year, a 7th year. You can as well start preparing to replace it and capture it in the budget. But what we have is we don't have it as that robust. And if we have that mechanism, it starts creating a solution. It doesn't give the magic bullet, because these machines are also the most expensive. They are the most capital intensive. So if I'm replacing what is called a CM or image intensifier X-ray for doing X-rays while I'm operating, and it is costing me 8 million, when I set the budget, my finance person will tell me what revenue are you generating first, because you can only spend what you've generated. And the second bit is, so we have generated this much. Number one, we have to take care of the payroll. Otherwise, the staff will not wake up, dress up, take a matatu and come to work. They do that because they know at the end of the month they will have a salary. So the first assignment becomes the salary. The second is the patients have to eat, the patients have to consume drugs, the patients have to consume certain surgical consumables. So the supplier becomes number two. This is now the operational issues that happen on a day-to-day basis that maybe the biomedical team is not privy to. And now number three is we've certain this, now let's fix our capital expenditure. So capital expenditure is always number three or number four. And sometimes later in the month or later in the year, because even if you made the budgeted revenue for quarter one, you are not set in quarter two, you're not going to have issues and you make a surplus and deficit. So usually you tend to see CapEx will be really taken care of towards the third quarter and the fourth quarter of the financial cycle, because we are certain we have made some surplus, and therefore we can use this surplus for the CapEx, capital expenditures, so to speak. So that balance becomes difficult, and therefore if you have a long, protracted kind of a schedule where you know our mandatory CapEx for this year is this, next year is this, the year after is this, it becomes very good. The issue that keeps confusing even the finance sections is where everything was going well until today, around 10:30 a.m. when machine A broke down. We have done everything within our means, but we are sorry to declare that we are going to write it off. Then you go back to the drawing board.
I think one of the best things you've just said, according to me, is the idea of data-driven decision-making. And if we could get that kind of data from all the hospitals and all the clinics and, across Kenya and across Africa, I feel like we could do a better job of planning for what kind of equipment do we need to be thinking about manufacturing on the African continent to solve whatever issues that we have.
Absolutely, absolutely. In my journal, unfortunately now because of blinding, I can't share a lot, but there is a paper that was coming from Mozambique. Unfortunately, after we spoke, I went, looked for it and realized it went through the manuscript stage and we had to return it to the author. But the author was raising very valid questions. He was asking for the African market. Why are you telling us that what you've decided in Europe is what should apply in the African market? You can drive a Mercedes-Benz in a nice, smooth, cabro-paved driveway. You can't take it for rhino charge. Yeah. So what is good in this context is different in the other context. And therefore, we need to contextualize and ask ourselves, can you have a checklist of saying, under these circumstances, this machine should have 1, 2, 3, 4. When the weather changes, when there are fluctuations in electricity, all those things combined. And I'm happy to, be able to help in whichever way we can do, but gathering this data will go a long way in helping kind of drive a policy communication. But when it comes to the operational communication and the budget communication, every institution stands on its own feet.
Exactly.
Yeah, every institution stands on its own feet. If I have machine breakdown, my neighbor will be happy because the patients will go there. so those are the other issues we see in the prevailing market environment. But I think from a policy formulation, and I've always, my next big question, this I keep posing is, where does the association come? Because sometimes you look at certain jurisdictions, associations drive guidelines and everything, and we see that in the country. And our constitution also says the policy and the guidelines and all accreditations and giving standards belongs to the MOH. But when you look at certain policies, you realize, you have treatment guidelines that are 15 years old, and maybe they abandoned that because they didn't have a funding for a task force. So there is also that conversation to say, Ministry of Health, you drive policy, but how robust are you and how up-to-date are you, especially when you have a cash crunch in terms of financing? Because also sometimes there's a lot of donor aid that comes in to support such programs, and you don't know where is the pull factor and where the push factor is. So a donor comes and says, I have this project, I need us to prepare treatment guidelines for snake bites. I'm like, snake bites maybe are affecting 10% of the population, maybe 5 million of the 54 million Kenyans. But because there is money, what harm does it give? And then another donor comes and drives something. But for us, what is our healthcare demanding? What is it asking for? Because that is where we should be pushing it. So I feel that coordination still needs to be there and driven. Probably associations maybe the ministry just needs to have a liaison person with the various associations. Say, Surgical Society of Kenya, surgical treatment guidelines, I expect to come from you. We will give you secretarial support, maybe. and give the logo of the ministry and print the booklets. Gynecologist, you prepare your treatment guidelines, we are going to support you. But what we see sometimes is if the association is driven, they will do the guidelines, for instance, and create some policies, and then maybe the ministry will also adopt them and domesticate them. So there's a little more that we need to do, and I feel this conversation will come in handy. But I'm happy to partner to see how we can drive data from what is the downtime, especially if you just picked how many machines do you have, what are your downtime, and you have a national Google Drive where people keep inputting. You will have the most immense data I have found. And I'm happy to assist with that because courtesy of what we do in Kikuyu, we found that I can even sit now and tell you our machine downtime is a problem because we've created a culture of talking about it every month and looking at it. And now we have started identifying the problem because the first solution to any problem is first to identify and recognize there's a problem. Thank you.
Thank you.
Thank you very much, Dr. Aruyaru. I think we'll continue this conversation at the conference. Looking forward to seeing you there.
I look forward. Thank you. Thank you so much for having me. I had fun talking about biomedical equipment. It's not one of those common conversations I usually have, but definitely it was an important conversation to have. So thank you to both of you for having me.
Karibu.